Production and distribution of City Club forums on ideastream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Cleveland State University, Robert Conrad, and the Payne Fund.
Good afternoon and welcome to the City Club of Cleveland. I'm Deborah Green, Vice President of Social Responsibility and Chief Diversity Officer at Medical Mutual, the oldest and largest health insurer in Ohio. I'm also a 21-year breast cancer survivor, so this is especially endearing to me to have Dr. Lynch here today, and I'm glad that you're all here. On behalf of Medical Mutual, it's my pleasure to welcome you here and to introduce today's forum on breast cancer, a conversation with ideastream's Managing Producer Kay Colby and Summa Health breast surgeon Dr. Melanie A. Lynch. October is Breast Cancer Awareness Month, an annual international campaign to raise awareness of the disease and raise funds for its prevention, diagnosis, treatment, and cure. Despite growing awareness and new developments in prevention and detection, 1 in 8 women, approximately 12% of the population, will develop breast cancer in her lifetime. And it remains the second leading cause of cancer death in women. We sometimes forget that beyond these scary statistics are personal stories. Stories of women we know, women who are daughters, wives, mothers, professionals, and friends. Each with a story filled with heartbreak and determination, grief and strength, fear and redemption. Stories that we don't hear often enough. And today we'll hear one such story. The story of Dr. Melanie A. Lynch, a breast surgeon at Summa Health who had the unique dual experience of being the doctor treating women with breast cancer and becoming the patient who was cared for by her very own team after being diagnosed with breast cancer in 2015. A graduate of Stanford University and the Ohio State University of Medicine, Dr. Lynch spent 4 years as section chief of general surgery at the Lewis Stokes Cleveland VA Medical Center before joining the staff of Summa Health as a surgical oncologist and director of their interdisciplinary breast program in 2012. Interviewing Dr. Lynch today is Kay Colby, a 7-time regional Emmy Award-winning journalist who logs more than 30 years in broadcasting and serves as the managing producer of health for WVIZ, PBS, and 90.3 WCPN ideastream. She joined ideastream in 2009 as a founding member of Be Well Team, which has produced numerous award-winning television and radio stories about health issues ranging from diabetes and obesity to childhood-led poisoning. Ms. Colby's work at ideastream has been recognized with several national awards, including the inaugural June L. Beadler Prize for Cancer Journalism from the American Association for Cancer Research. Prior to joining ideastream, she served as principal investigator of 5 grants funded by the National Cancer Institute to conduct video and television outreach campaigns for low-income African Americans about cancer prevention and treatment. And having spent a few minutes with Kay and Dr. Lynch, you are in for a wonderful afternoon. She has a wonderful story to share. And again, thank you for being here, and I'll turn things over to Kay.
Thank you, Deborah. And on behalf of ideastream, I want to welcome everyone in the audience, as well as those who may be joining us by watching on TV or the internet. I hope this is really going to be an engaging and informative conversation. According to the American Cancer Society, in 2015, 232,000 women received a diagnosis of invasive breast cancer. And as Deborah pointed out, behind each one of those numbers, there's a personal story. And I am honored to be here this afternoon to help tell the story of Dr. Melanie Lynch. you know, it takes courage, it takes self-reflection to want to be able to share your journey. So I just want to thank you, you know, right off the bat for being willing to do that. And what I thought we would do is kind of go back in time and, you know, recount your experience, what it was like to go from being, you know, a professional who was delivering cancer care to someone who then had to become, you know, on the receiving end of it.
It was quite a journey. So I started at Summa in this new position as the medical director of the breast program there at the end of 2013. And at that time, we set 3 goals for our program to improve our services. The first was to improve access, to streamline the process from mammography through diagnosis and into treatment, to make that timely and to make that supportive by adding patient navigation and education programs. Our second goal was to build interdisciplinary team-based care, where we weren't practicing in separate silos, but everyone who cared for breast cancer patients, from the physicians and nurses to our physical therapists and nutritionists, worked together as a coherent team. And then our third goal was innovation, bringing new surgeries, new approaches to care, new approaches to cancer survivorship. And so we had just kind of actualized many of those goals. We had streamlined our services so the time from diagnosis, or from abnormal mammogram to diagnosis, had been reduced from over 20 days to 7 days. We'd put a patient navigator in place to help with that whole process. We had built a new breast center, a whole new way of delivering care, and we had developed some new and innovative surgeries, including oncoplastic breast surgery, nipple-sparing mastectomy, and just in time for me to get a diagnosis of breast cancer. So earlier in 2015, we had implemented tomosynthesis, which is 3D mammography, which has improved the diagnosis of breast cancer. And so as the year was winding down, I found myself in my primary care physician's office and found her scolding me that I hadn't had a mammogram in quite a while. And so I went on a Friday afternoon, the last patient of the day, to have a mammogram.
So take us back. You get your screening mammogram, which you had put off like many of us do. And how soon after did you know it was not normal?
So my experience, of course, is a little bit different because I had kind of an inside track. So as I had my mammogram that day on Friday afternoon at 4 o'clock and the technician brought the images up, I was looking over her shoulder and I just had that sick feeling in my stomach, which was maybe the same feeling. Any of you who are breast cancer survivors know that feeling, when either you got the letter in the mail or the telephone call saying, this is not okay. And so I had the good fortune to have my friend who is a breast cancer mammographer who was available to look at my film. And then when she started putting big arrows on the mammogram, I kind of knew what was happening.
So what went through your mind when you see that on the screen and, uh-oh, this is me?
Again, it's about living in the moment. So I didn't want to jump too far into the future. But I have to say my primary concern was, if I need chemotherapy and I develop a neuropathy, I'm not going to be able to do surgery. And through the initial part of my evaluation, that was my biggest concern. Will I need chemotherapy because of the disability that might be associated with it?
Wow, so what happened from there? You have the abnormal result.
Right.
You go for a biopsy, a
Right.
stereotactic.
Core biopsy, right. So our system of navigation worked very well because I just kind of put myself right in the line. They had an opening, and it happened to be on a day when I was in clinic in the breast center. So I was able to see patients, run down the hall, get my biopsy, and go back and finish my clinic that day. So that worked out pretty well. But
From an emotional standpoint, let's just go back. You're seeing patients, you run down the hall, tell me about that. That had to be
Well,
really
I have to
hard.
say the stereotactic core biopsy was quite an experience. I don't know if anyone here has had one of these biopsies. Yes.
Can you back up and explain, first of all, what it is, how it works?
Well, this biopsy has transformed the way we treat breast cancer in this country, because when we do a screening mammogram, if you find an abnormality, you have to find a way to biopsy it You can't just look at it and say, well, I don't know what to do with it. So stereotactic core biopsy was developed way back when I was in medical school in the 1990s and is now the standard of care for the diagnosis of breast cancer. And so when you have these areas of abnormality on the mammogram, you have to find a way to get a needle there. And so what you do is you immobilize your patient, they're awake, you put their breast in compression. All of us have been through this experience if you've had a mammogram, for about 15 or 20 minutes. And while your breast is in compression, they then guide a needle into the site and sample this area. So you're basically held still with your breast in compression with a spike in the middle of your breast. And everyone there is very friendly and nice, and they're talking to you while you're going through this. But I don't think there's any kind words that makes that any easier. And I send hundreds of women to have this done every year. And so it was getting a bit of my own medicine to have this same experience.
So has that changed, having gone through it yourself now, has that changed like how you try to prep women? Like, I know what you're going to be going through more.
I don't talk about my own experience with my patients. I do have much more empathy as I talk to patients. And there are multiple approaches to help making this experience better. One, you can always use medication. There are always mild sedatives that you can give patients, and I always offer that, and I did offer that before I had my experience. And then there's mindfulness techniques, there's a meditation, there's aromatherapy techniques that have been used to help make these experiences less stressful. So in that regard, we always try to make it easier, but I have to say there's only so much you can do. It is what it is.
So you said something interesting. You don't talk about your experience with your patients. Why not?
Because when I talk to a patient, it's about them. Okay. And so it's about them. And what I would find is many times they might, I can imagine they'd say, wow, how are you doing? Okay. And so it's not about me when I'm in the room with a patient, it's about them.
So let's get back to your story. You do the biopsy, and then how did you get the news that there was bad news? How did you hear that?
So at the time that I had the biopsy, we were pretty clear what the diagnosis was likely to be. And at that point, I talked to one of my dear colleagues and friends who's a very, very skilled and thoughtful breast surgeon. And I asked her if she would be the one to take care of me if this turned out to be breast cancer, and she said absolutely. And so she's the one who then followed the result and called me with the result. In giving this kind of news to patients, I always ask patients before the biopsy, is it okay if I call you and we talk by phone, or would you rather come in and have an appointment to discuss your result? So we had already agreed that the minute she had the information, she should call me with it. And the day that she called me was the day that I was in the operating room and in between cases. And at that point, I knew what the treatment was going to be, and I knew how things would go. So I didn't have an overwhelming sense of dread. But I can imagine if I didn't have the same experience and knowledge, how that feels when you're at home getting that phone call from the physician is probably one of the not best days of your life.
Because that was one of my other questions, is now that you've been on the receiving end of that kind of news, has it changed how you deliver it with your patients?
I'm very deliberate about making sure that we set the stage. And so many patients are like, yeah, you can call me with the result. But as I have that conversation now, I want to make sure they understand what it might feel like. You don't want to call someone and have them pick up their cell phone and be in the car, right? Because that's not a good time to talk, but they're going to want to know right away. So I'm a little bit more deliberate about setting the time for the phone call if it's going to be by phone.
And you were in the OR doing a case when
I was
you got
in between
your news?
cases,
Okay.
yeah. And I really felt okay with it and confident with it and felt like I could move forward with the rest of my day.
Do you think that's because you kind of had a gut feeling anyway?
Yeah.
Okay.
Yeah.
And so who did you share? You have 3 children. 2 of your daughters are here. It's nice. And did you tell your adult children right away, or how did you share this with your family?
And this is, the literature on cancer is pretty clear about talking about results and communicating with your family, that it's better to tell people right away. This isn't something to keep a secret or something to try to spare somebody from this information. So that right away that day I called all of my family members to let them know. And everyone had their own reaction. But it was just an overwhelming sense of love and support, and so it was very, very gratifying, and it kind of helped give me more confidence that it was all going to be okay.
And so then you move into the phase, okay, I call it treatment decision time, which I've interviewed a lot of patients, a lot of families, where it becomes overwhelming. You're just bombarded with all this medical jargon and information, and it's very stressful. How was it for you, knowing that you had this is your profession?
Right. So the most important thing is to develop a trusting relationship with your physician. And sometimes you have to talk to a number of different physicians till you find the right match. And my partner, Dr. Vicki Van Fossen, is a tremendous physician and a friend. And so we were able to talk about it in a way that felt very familiar, which always brings us back to the discussion of informed consent. Can we really ever truly be completely informed about what these treatments are going to mean in our lives? You just can't. You can do the best to educate yourself, to meet physicians, to get second opinions, and to really bring together as much information as you can so you can make that leap of faith. Because most of us, when we're diagnosed with cancers, we feel fine. We don't have any symptoms. We don't feel bad. And we know the treatments are going to make us feel bad. And so you have to have faith that that treatment is going to help prolong your life and help you live better. And how you collect that information to make that decision is a process. And for some women, it takes longer than others. And so she and I were able to sit down and kind of very quickly kind of go through the steps and say, this is what's the right thing to do. At that point, I knew I had to have a mastectomy. She agreed, and how you make that decision between breast conservation and mastectomy is very individualized for every woman. But for my case, that was clear that was the right thing to do.
So you had the clinical part figured out. You had a mastectomy and reconstruction at the same time?
Correct. I had.
What other issues, though? So you had the clinical part figured out. What other issues were you surprised came up during this whole treatment planning process?
Right. So with a cancer diagnosis, it disrupts every aspect of your life. And so that's why it's important to have a team that can help support you as you go through something like that. And the concerns start with nutrition, exercise, physical abilities, potential disabilities that can come with cancer treatment, financial concerns that come with cancer treatment. How much will this cost? How will I pay for that? What will this mean for my job? How much time off do I need? What will that mean for me in the future? And all of that comes up at that same moment that you're trying to make a treatment plan.
And Melanie, I think about, I've done a lot of work in health disparities, so you have this great career and a wonderful job, but what about the women who are living paycheck to paycheck? Maybe they can't afford to take 6 weeks off to recuperate from surgery. Has this changed how you view those kind of situations?
I would say I feel as helpless to address that now as I did before my diagnosis. When patients declare bankruptcy during the course of cancer therapy, their cancer outcomes are worse than patients who have financial stability during their cancer treatment. So economic justice is part of making sure patients have a good outcome from cancer. And the Institute of Medicine report on quality cancer care that was published in 2013 has 6 core recommendations for improving the quality of cancer care. And one of those is financial counseling and support, helping patients get through their treatments, helping them with transportation to get to the hospital. Many women choose a mastectomy instead of breast conservation because they don't have transportation to get to the hospital for radiation therapy every day. So those are the kinds of concerns that we need to improve. We need to do better at day-to-day living concerns.
A lot of women. So what was it like the night before your surgery? Were you anxious? Were you scared? What did you do and what went through your mind?
So I had wonderful family support. So I had family that kind of came in from all over the country to be present for the day of surgery and to help me afterwards. And that was really gratifying. It's very difficult to move from the position of being a caregiver to needing care. And I don't know if I did such a good job at that, but I did my best.
Why do you say that?
I want to do it myself. And I'm sure many of you are like that too. It's very hard to kind of become patient, especially when you're used to being doctor.
And was it weird, like the morning of surgery, I can imagine, your colleague, your partner is scrubbing in, and you're used to being part of the team, and now you're lying on the table. Was that a weird feeling?
Yes, it was. I would say that the most important thing is to give up control. And so, when the IV was going in, I was certainly not giving advice about that. When they talked to me about the anesthesia plan, I just, I was going to be a good thing I was under the blue paper during the operation, right? I was asleep, so.
So what surprised you most about your surgery and your recovery? What's been the most surprising thing?
So the most surprising thing about surgery is how little pain I had after the operation. So in my training as a surgeon, one thing that was made very clear is we want to make sure we're treating patients' pain. We don't want to leave our patient with postoperative pain. And so the amount of pain medicines I would prescribe for patients after surgery was tenfold higher than what I needed after my surgery. And I think that we rely on narcotics for pain control more than we need to, and that there's other ways of treating postoperative pain. And this includes physical therapy before and early after surgery that makes a big difference. So I would say that was the most surprising aspect of my operation.
Wow, and that's something you can implement clinically. You don't have to
Absolutely.
prescribe all the
Absolutely.
heavy-duty drugs.
And I have other options that were very effective for managing postoperative pain.
And you talked about the lymphedema with your recovery, having all
Right.
that pain in your arm,
Right.
which for a surgeon, I imagine, is kind of a scary thing.
Right, exactly. So in any surgery or any cancer treatment, there are associated side effects and associated disabilities. And we try to help identify those prior to treatment and do things we can to ameliorate those before treatment. That's called prehabilitation. And then after we've provided the treatment, then provide all those resources as rehabilitation. And so I was young, relatively healthy, and didn't expect to have significant problems after my surgery. My surgeon made me promise that I would do exactly what she said, which was not to operate for 6 weeks after surgery, which I did not. When I went back to the operating room after my first day of surgery, I scheduled a full 8-hour day of surgery that day, and went home at night and found my right arm, which is the cancer side, was swollen. And this was an example of what's called lymphedema, or arm swelling that can happen after the lymph node sampling that's part of breast cancer care. And I was surprised, and I didn't expect that to happen to me.
So given that, do you think there are, during the surgery, there are ways to avoid taking so many lymph nodes?
Well,
are you an advocate for that women should discuss that now?
Yeah,
with their
so
surgeons?
the lymph node sampling at the time of surgery is for staging of the disease. It's not truly therapeutic, it's for staging. And we used to perform a complete removal of all the lymph nodes at every breast cancer operation. Now the standard of care is to do a sentinel lymph node biopsy where we remove few nodes, 1 to 3 lymph nodes, to help with staging. And that technique is the standard of care now. And that was the same technique that was used with me. The risk of lymphedema with a sentinel lymph node biopsy is 10%, less than 10%, and with a full axillary dissection is 25%. If you add radiation to that, the risk of lymphedema is 50%. And so this is not insignificant in terms of a postoperative disability that we need to monitor for, diagnose early, and aggressively treat.
And you also mentioned physical therapy, and that gets me on the subject of exercise. Mm-hmm. And I have done a lot of reporting on the benefits of exercise during treatment and after. Tell me a little bit about what you see as the benefits.
So the exercise as part of prehabilitation for cancer therapy is very important. Anytime you can build muscle mass, it's going to help you do better. And then as part of rehabilitation after surgery, the first exercises for women after surgery are range of motion to help maintain full function in their shoulders. And then it's about building muscle mass back. But we know that exercise improves cancer survival. So the recommendation of the American Cancer Society is daily physical activity with vigorous physical activity for at least 30 minutes, 3 times a week. That's where you get your heart rate up, you break a sweat.
And that's during chemotherapy. They want you to exercise during treatment.
Yes. And exercise, especially the daily physical activity, walking every day, helps with cancer fatigue. And cancer fatigue is one of the overwhelming symptoms that sometimes can interrupt your therapy. And so that's why starting exercise for all of us as part of wellness, but as part of prehabilitation and then in that time after cancer care is important.
So what's the most important thing you've learned, and what do you want other women to learn from your story?
Cancer survivorship is a daily practice. And so for all of us who are now cancer survivors, who might be cancer survivors in the future, or who are at increased risk for cancer, there are 5 things that we need to do every day. So the first is daily physical activity with vigorous exercise 3 times a week. We can all do that now. And for those of us who are cancer survivors, we'll live longer if we do that. The next is eating a plant-based diet. So it's our animal products that carry the environmental estrogens in our diet. So the more we can make sure we're on a plant-based diet, we can help eliminate those. And the American Cancer Society clearly supports 5 servings of fruits and vegetables a day. By the time you've eaten that, there's not much room for anything else. So a plant-based diet. We have to stop smoking right now. And we have to tell everyone we know that they need to stop smoking now. That's one of the most important things we can do. Alcohol has estrogenic effects. And so less than 4 alcoholic drinks a week helps reduce your risk for breast cancer and helps improve your cancer survival. And then maintaining a body mass index as lean as possible. Now this recommendation, it's hard to get your arms around it literally about what an ideal weight is. A body mass index is a height to weight ratio. And for some women that's going to be higher than others. So at the time of a cancer diagnosis, you don't want to gain weight. And then work with your physician to determine what's the best body mass index for you, and then work to maintain that.
And something interesting I learned is a lot of women actually gain weight on chemotherapy. I was surprised about that.
Well, steroids are part of the treatment, and then endocrine therapy, which is a part of breast cancer therapy, can also lead to weight gain.
And do you think the public is getting the relationship between obesity and certain cancers? I mean, and breast being one of the ones that the fat cells can actually feed certain breast cancer cells?
So, and the issue of weight gain with breast cancer risk is really postmenopausal weight gain. So women who gain weight after menopause, this will increase breast cancer risk about up to 50% above the baseline population. So that's the time to really watch weight gain.
And that's the easiest time you gain, really. It's hard.
It's not fair, no.
No, it's not fair. So we are today enjoying a forum on breast cancer featuring Summa Health breast surgeon and breast cancer survivor, Dr. Melanie Lynch. We're about to begin the audience Q&A part of the program. We welcome questions from everyone, City Club members, guests, students, or those of you joining us via our webcast. If you'd like to tweet a question, please tweet it at the City Club, and our staff will try to work it into the program. We want to remind you that your question should be brief and to the point. And holding the microphone today is Marketing and Outreach Coordinator Faye Walker. May we have the first question, please?
Oh, okay. What stage cancer were you when you found out you had cancer?
Stage 1.
Thank you for that. Anybody else?
Double mastectomy.
What an interesting question. So I can tie those 2 questions together. So the treatment of breast cancer is based upon stage and tumor biology. So the stage of the disease is based upon the size of the tumor, the involvement of local lymph nodes, and any sign of metastatic disease. We have a clinical stage based on what we think the size of the tumor might be, the involvement of the lymph nodes might be, and that helps us shape our treatment plan. The other component of developing a treatment plan is the biology of the tumor. And this kind of moves towards a discussion of precision medicine. We currently evaluate breast tumors based upon what drives their growth: estrogen, progesterone, and another receptor called HER2, which when it's overexpressed on a tumor cell tells that it's a more aggressive biology. There's another type of breast cancer called triple negative, which is the most aggressive. So I had a very favorable early stage tumor, but a relatively large amount of tumor relative to the breast, which is why I chose to have a mastectomy. Now, with regards to a double mastectomy, I think it's very important to know that removing the opposite unaffected breast does not improve cancer survival. It only improves cancer survival for women who have a mutation in a known breast cancer-related gene. So a double mastectomy improves survival for women who have a BRCA1 or 2 mutation or one of the other 8 BRCA-related genes. So choosing a mastectomy on the opposite side, a preventive mastectomy, does not improve your survival.
And Melanie, that brings another really important subject, the genetics. So you opted to do genetic testing. Tell us a little bit about that and why.
Sure. So about 30% of women with a breast cancer diagnosis will have genetic counseling and testing as part of their evaluation. So the indications for genetic counseling and testing are being premenopausal at the time of diagnosis, which was my situation, being younger than age 60 and having a triple negative breast cancer, one of those aggressive biologies, or having a family history of breast and ovarian cancer. And that would include any male breast cancer, any ovarian cancer, or close relatives or an assembly of distant relatives that have had a history of breast cancer. And so when you think about those criteria, that's about 30% of women who would benefit from counseling and testing.
And I think a lot of people get the whole genetics field messed up with the genomic testing of tumors. So tell us about the genomics, and you alluded to it with the precision medicine. They're actually going in and looking at the DNA footprint of the tumor to find out if that cancer will respond to certain therapies. Is that the idea?
Right. So that's why I was so delighted that this lovely young woman asked me the question about cancer stage, because the way we manage cancer now, it'll be very different for your generation. What we're going to do 10 years from now will not be at all the way that my cancer was managed. So right now, when we stage breast cancer based on size of the tumor, involvement of the lymph nodes, we do that because that's what we know how to measure. What's really important is understanding the biology of the tumor, and that's genomics. That is understanding the gene expression profile of each tumor. Because we know a 3-centimeter cancer with this biologic feature is curable, and a 1-centimeter cancer with this biologic feature is going to be difficult to treat. And as this field of precision medicine develops, we'll have better and better measurements of tumor biology to understand how these tumors will behave differently. These are the gene expression profiles that are finding their way into clinical practice currently.
So when you take a tumor out of the OR, then they go and they can test it to see if it has one of those markers and...
Right. So the markers that we test currently routinely on every cancer is estrogen, progesterone, and HER2. Some tumors, based on their size, lymph node involvement, will then send a gene expression profile. One of them is called an oncotype. That will help us identify high risk versus low risk, and which women would benefit from chemotherapy, and which women can avert chemotherapy because of their gene expression profile. We will start to do these gene expression profiles at the time of biopsy, and that will then guide new forms of therapy. We'll use ablative therapies instead of surgery. Some women will use more aggressive surgery. Some women maybe even bilateral mastectomy, because we have genetic information that will guide us.
So right now, though, they do it from the tumor after you remove it in the OR.
Correct. And we will move that back into the realm of the biopsy specimen, I would expect within the course of my career, within the next 5 to 10 years.
Any more questions?
Good afternoon. So you were saying you were in your primary care physician's office and he or she was chastising you about having gone a while without getting a mastectomy. What was holding you back? I mean, you were right there in the office. And what do you think we can do to get more women to more regularly go through the compression experience?
So that's a great question, and there's nothing like a little personal experience to help. So I never perceived myself at risk for getting breast cancer. Now remember, 75% of breast cancer is diagnosed in women with no family history. The vast majority of breast cancer is in women with no family history. So you're at risk if you're a woman. You're at risk as you get older. The average age of diagnosis of breast cancer is 62. The average age of a breast cancer death is 68. That's a relatively young age. So that's why early diagnosis makes a difference. Now the recommendations for mammography are kind of all over the map right now. In general, by getting annual mammograms when you're in your 40s, you reduce your risk of breast cancer death by 15%. That sounds pretty good to me. But many women get mammograms, they have dense breasts, you can't see everything. So the controversy is, what age do you start, 40 or 45? So the American Cancer Society kind of said, well, assess your risk based on family history and other factors, and start at least age 45, maybe age 40 if you're at increased risk. That seems reasonable, but I think we all can agree that women who are in their 40s should be getting mammograms every year, every other year. For women in their 50s and 60s, this is the key time when breast cancer is diagnosed. Annual mammography makes sense there. And then as women age, getting to be age 70 or 75, there will be some point where stopping annual mammograms does make sense. Now, women are living longer. So if you're 70 years old and you're relatively fit and you're likely to live to 90, well, should you stop at age 80? Should you stop at age 75? Are we going to end up diagnosing an early stage cancer that may never become clinically relevant? That's the controversy around overdiagnosis. But it still makes sense to have that information, right? And so it still makes sense to have those mammograms to give you a baseline, and then you can assess your own personal risk from there.
You brought up early diagnosis, and I think that's a huge issue right now. There was just the study in the New England Journal of Medicine by the Dartmouth researchers that are saying with the 3D mammography, we're able to find these tiny, tiny little abnormalities that may not even be cancer or may not even turn into cancer. So how do we make sense of all these recommendations and differing opinions?
Right. So the issue of early diagnosis. When Nancy Reagan was diagnosed with breast cancer back in the 1980s, we saw a huge uptick in screening mammography. And with that uptick in screening mammography, we saw an increase in breast cancer diagnosis of early stage tumors and of favorable biology, these estrogen receptor positive tumors that are treatable and curable. When Bernadine Healy became the first woman to head the National Institutes of Health in 1992. The first thing she did was implement a $50 million multi-center clinical trial, which was a big investment at that point. This clinical trial looked at hormone replacement therapy at the time of menopause. It was the first time this had been studied in a double-blind, randomized fashion. And in 2002, we had the data that showed that hormone replacement therapy at the time of menopause is associated with an increased risk of breast cancer, heart disease, and stroke. When that data was published, women stopped taking hormone replacement therapy at the time of menopause. In fact, that hormone replacement therapy dropped off by 70% over a 2-year period. And we saw the rates of breast cancer at that point drop by 1.7% per year for the next 5 years. So we saw a dramatic decrease in our breast cancer incidence when we stopped hormone replacement therapy at the time of menopause. So we found more of these breast cancers that were early stage and ER/PR positive when we started screening more, mid-1980s. We saw a drop-off in those cancers in the mid-2000s when we stopped hormone replacement therapy. So the bottom line is, with screening mammography, we are picking up earlier stage tumors, often estrogen receptor positive tumors, and we can still do things about those tumors. So screening mammography does make sense. Screening mammography has not helped reduce the incidence of aggressive tumors like the estrogen receptor negative tumors we talked about a little bit earlier.
The triple negative.
Right, because those tend to grow fast, they tend to show up in between mammograms, and screening doesn't necessarily improve outcomes for those more advanced stage or more aggressive biology tumors.
It just seems like we're getting more and more into how breast cancer is so complicated based on the biology. I mean, all these different recommendations depend on the biology of the tumor.
Exactly, and the only way you'll know it's there is if you have a screening mammogram. And then you get a biopsy, then you know what's there. And we'll tailor our treatments more to the biology of the disease.
I have to ask about breast self-exam. What is your view? Is that something we should still all be doing?
Absolutely. So 20% of breast cancer is still diagnosed by breast self-exam. Someone finds a mass on their own exam. And so being familiar with your body is important. The clinical trials suggest that it doesn't make a difference, but clinically we know that it does. The patients that I'm most struck by are older patients, women in their 80s who come in with a relatively large cancer, but because they had not continued with breast self-exam, they hadn't continued with mammography, the tumor was then diagnosed at a later stage. So they're complementary. Self-exam and mammography go hand in hand.
And you think it's important because your body changes with age. It certainly changes after menopause. So if you do those exams regularly, you're going to be in tune with the change?
Correct. Correct.
Any more questions?
Hi. I have a question for you. Thank you so much for sharing your story, Melanie. It really means a lot. A little bit off of the medical and to the personal, I am curious about your feelings about body image and how those affect women who are looking for care and how we even talk about breast cancer, because I think often people aren't considering the impact that it has on women.
So the treatment, I'll take it from a treatment perspective and then move backwards. So when women are diagnosed with breast cancer, and we come to our first treatment planning session, what I hear from patients across the board, and their very first thing is, I want a double mastectomy. I want my cancer cured. I want to know I have done everything I can to cure this cancer. And that often won't improve their outcomes, but they want to feel like they've done everything they can. And what I say to patients at that moment is, most breast cancer is curable. 87% of women are going to have a cure and live a long life afterwards. So what I ask my patients to do is say, imagine yourself as a 90-year-old lady. This is the body you have. This is the body you're going to carry forward. Let's make a treatment plan that will leave you with a body that you'll be glad to have when you're 90 years old. So the highest patient satisfaction for women is with breast conservation. That's the highest long-term. Sometimes that's not possible for patients, and so we now have developed all sorts of new surgical techniques, including oncoplastic reductions, new ways of doing breast conservation that improve the cosmesis afterwards, nipple-sparing mastectomy, immediate reconstruction. We have all sorts of ways to help to treat the breast cancer and cure the breast cancer, and then leave someone with a body that they're glad to live in until they're 90 years old. So the treatment of breast cancer does change and can create some disability, but we have ways now, surgical and rehabilitation techniques to help women get back to their lives. So.
You said something interesting when we talked on the phone. The night before your surgery, you went to yoga, and you were thinking, am I going to be able to do this again?
At the time of a cancer diagnosis, it's overwhelming. And I wasn't sure if I would have the strength or the ability to go back to my usual practice, to my work. And there was, a few weak moments there as I was getting myself ready to face the operating room the next day.
And how are you now, physically and emotionally, with the cancer part of your life?
I'm back to yoga, and I'm back to work. And I feel very fortunate, because at any point I could have had a positive lymph node, I could have had the stage of my disease could have changed, the biology could have been something different. So I'm very grateful for the treatment team that I had. I had just the best care possible.
Do you think it's changed how you're now delivering care because you've been on the other side?
Yes. And I think the things that surprised me have changed what I do. The idea of getting patients ready for treatment with prehabilitation, the idea of aggressively integrating physical therapy into care prior to and immediately after surgery, the idea that the financial concerns that come with a cancer diagnosis can impact your therapy, and making sure to find ways to address that earlier rather than later. And how we manage pain. We can do a much better job in how we manage pain.
Prehabilitation, I have not heard that term. That's a good one. Any other questions from?
So when we talk about 2D and 3D mammography, oftentimes women have decision making when they come because providers are not reimbursing for 3D mammography. So can you speak to some of that decision making and why a woman might opt for that added cost?
Sure. So the difference between 2D and 3D mammography, a 2D mammogram is two views. You kind of compress the breast, shoot from this direction, compress the breast, and shoot from this direction. That's standard mammography that we have had and that we know is reliable for screening. 3D mammography captures multiple images across a sweep. So the breast is placed in compression and the camera moves, or the device moves around the breast and will create up to 60 images of the breast. So it's like trying to look through a cover of a book versus looking at each individual page. So it doesn't take any longer than a standard mammogram. It does take a little longer to read. Dr. Lauren Kinzel is here, who's a breast imager and the medical director of our breast imaging program at Summa. So she was instrumental in helping implement 3D mammography at our location. So the benefit of 3D is first for women with dense breast tissue. It gives us a better view of that tissue than standard 2D mammography. 3D mammography also reduces callbacks. How many of you have had a mammogram where they said, there's something on your mammogram, come back and get more views? So those callbacks have been reduced by 30% with 3D mammography. So that kind of reduces not only cost, but anxiety. 3D mammography can pick up some cancers earlier and has a higher cancer pickup rate. It also seems to be picking up earlier stages. So ductal carcinoma in situ, which is non-invasive cancer, or even atypical hyperplasia, which is even upstream of that. It's like having an abnormal pap smear. So we're finding these earlier things, and we'll need to develop new clinical programs for treating women with these earlier lesions that are picked up on 3D. So I think 3D, just like when we switch to digital mammography, 3D mammography will become the standard for screening.
I just have a couple comments. One is definitely do your self-exams. I've had mammograms for years. I was a clean mammogram in September of 14. By January 15, I had a 4-inch tumor, and I found it. So definitely keep up on the self-exams. That's definitely needed. And my philosophy is I talk to anybody, any age, about breast cancer. I want everybody out there to know, young kids, young women, get on top of this so that they have an understanding. They ask to see, I show, I do anything they want so that everybody is informed as much as possible. But my question now to you is, I'm at the stage of what do I do with my nipples? Do I have them make them or do I tattoo them? What's your thought on that?
I have a lot of thoughts about that.
That's another big conversation.
But very important, right? I mean,
Absolutely,
very
because
important.
it goes back to body image.
Yes.
It goes back to body image, and that our treatments first cure the cancer, second make sure that you have a body that you're glad to live in. And so with regards to nipple reconstruction and nipple tattoos, there is a tattoo artist in Baltimore. His name is Vinnie Myers. And his sister developed breast cancer, and after her treatment, she came to him and asked him to create nipple tattoos for her. And he did. And since then, that's become all that he does because he's so skilled and good at this. He's been in national media regarding this, and he has developed a training program, and he now has 4 people in his practice along with him that do remarkable reconstructions and nipple tattoos. And so, as you can, I see a lot of reconstructed breasts, and I send many of my patients there, or recommend that they go there. And I had a patient a couple of years ago who got all of her friends together, and they got a party bus and went for the weekend to get the tattoos done. And these are just beautiful. And so the thing to think about with a nipple reconstruction is there will be a nipple there that will not have motor function. So it will always be an erect nipple. So you have to plan your clothing around that. That's one of the things to think about with a nipple reconstruction. The nipple tattoos look three-dimensional and can be really beautiful.
There's a gentleman in, it's one of the W's, Wycliffe or Willoughby, that he has devoted his practice now to nipple reconstruction. But I haven't gone for that consultation yet.
So.
I'm a little ways off from that yet. But,
Good, and I'm glad I see a lot of both. And usually as long as you're well informed and about that the nipple reconstruction will always be there, that some women are surprised by that it's always going to be an erect nipple. So.
Thank you, Andrea. One thing that we haven't talked about is I actually knew a man who had breast cancer, and he ended up passing away. I'm just wondering if you have words of wisdom, or how do we get gentlemen to realize that this also affects them?
Sure. So my experience at the Cleveland VA was very helpful in management of male breast cancer, because I took care of so many patients. Many of them were Vietnam-era veterans who had been exposed to Agent Orange. And so male breast cancer is commonly associated with a family history and a BRCA mutation. That's one aspect of the care of men with male breast cancer. And the second is the stage of diagnosis, because many men, there might be a mass in their breast, but they just don't suspect that it would be cancer, so they might come in at a more advanced stage. But the treatment of male breast cancer and the cure rate for male breast cancer is exactly the same stage for stage as it is for women. So it's a curable disease, and it's managed in the same way with surgery, endocrine therapy, possibly radiation or possibly chemotherapy.
Thank you so much for sharing. When you have a patient that has a cancerous tumor, would you suggest that they have a lumpectomy, or would you suggest, go further surgery?
Right. So the treatment plan is based on stage and biology, and when we develop a surgical treatment plan, it's based upon the individual patient. So if you have a large tumor and a small breast, it's hard to do breast conservation and leave someone with a good cosmetic result. So at that situation, we would consider a mastectomy. The highest long-term patient survival is with breast conservation. And so if there's a way that we can do breast conservation, I will always find a way to get a patient there. And that is a lumpectomy, meaning removing the area of the cancer with a surrounding clear margin, and then following that with radiation therapy. That's breast conservation. And so if we can get a patient there, we will.
Thank you, Dr. Lynch, for being here. Yesterday, Vice President Joe Biden was here in Cleveland as part of the Medical Innovation Summit talking about the Cancer Moonshot program. We've talked a lot about genetics and genomics and some of the new ways we're diagnosing and treatment. What do you think is the future of breast cancer? Is it a vaccine? Is it in prevention? Or is it in a cure?
All of those things. And so, because breast cancer is not one thing, so we think of breast cancer now as 5 different types of breast cancer based on their biological characteristics. And they all have different causes, and we will tailor the treatments to those separate biologies. And that's the importance of really understanding what the Precision Medicine Initiative through NIH is all about. So within the Precision Medicine Initiative, they're developing a cohort of 1 million patients, healthy and affected, and they're asking for voluntary participation in this, where the volunteers will give biological data. So they're going to give blood and tissue and access to your medical records. So that way they can follow you over the course of your lifetime and figure out what genetic susceptibility is associated with which disease states and which treatments are going to be effective based upon that. That's precision medicine, and that's going to be the future of breast cancer. As we discussed earlier, this idea of genomics, at the time of a breast biopsy, if we knew the exact biology of that tumor and how it was going to behave, it might be of low potential, and these are the kind of tumors we'll treat with ablative therapies, cryotherapy, radiofrequency ablation, something like that, and avoid surgery and avoid other treatment. We might be able, at the time of a small tumor, identify something that's going to be pretty aggressive and give chemotherapy immediately because we know that'll make a difference. We'll develop new therapies based upon these profiles that we will collect through these tissue banks that will be part of that precision medicine initiative. The Cancer Moonshot includes both precision medicine initiative and everything else. In that press conference that they gave yesterday, one of the biggest things they talked about was smoking cessation. So we know prevention will be an essential part of that. We know that removing environmental estrogens that we're exposed to through our diet will be an important part of breast cancer prevention in the future. That weight reduction and physical activity will be an important part of prevention. And that's all, the whole scope of that is part of the Moonshot Initiative, and I think that will be an important part of breast cancer care as we go forward.
So I think we're going to wrap it up and close with Deborah. Thank you so much for sharing with us.
Thank you.
Thank you, Dr. Lynch. Thank you, Kay. Today at the City Club, we've been enjoying a forum on breast cancer featuring ideastream Managing Producer Kay Colby in conversation with Summa Health breast surgeon Dr. Melanie Lynch. Today's forum is sponsored by Medical Mutual. Our community partners for today's forum include Greater Cleveland Nurses Association and Susan G. Komen, Northeast Ohio. We thank all of you for your support and your partnership. We also welcome guests at tables hosted by Friends of Dr. Lynch and Summa Health. Additionally, we welcome students from Hathaway Brown. Student participation in city, yes, let's cheer Hathaway Brown. Excuse me, student participation in City Club's forums is provided by the Loeb Foundation. We thank you all for being here today, and this brings us to the end of today's forum. Thank you, Ms. Colby, again. Thank you, Dr. Lynch, and thank you, ladies and gentlemen. This forum is adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.
Production and distribution of City Club forums on ideastream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Cleveland State University, Robert Conrad, and the Payne Fund.